you, Jennifer. What a fabulous tour de excellence of AMS and in surgical. Amazing work, very impressive, and it's great to see this being led by your team in a multidisciplinary fashion. So I think you've both put us right on time, so thank you so much. Despite technical difficulties, you've done very well. So we'll move straight into the panel discussion. We've been monitoring the chat, and I just wanted to encourage the attendees to please post your questions and comments in the chat as well. But to kick us off, Jason's provided some fantastic questions, which I'm happy to share. So for Michael and Jennifer, we're really interested to hear, in your clinical experience and expertise in ID and surgical, how would you judge the duration of therapy when prescribed, given the heterogeneity of the variety of patients that you see in terms of the size of collections and intra-abdominal infections in particular, because that's something that we see in practice that varies quite a bit.
Do you want to go first, Michael?
I'm pretty simplistic. If you've got a gut that's working, then use it, is my first thing. The source control, which you mentioned, I think is really salient, and it's something that the AMS teams really bring to the forefront of our mind in the last couple of years. Have you got source control, and what can, and if not, what do you think you can do it, and if so, by what means? But generally, from an intra-abdominal infection point of view, if their gut is working, that means that the infection there is not causing ileus and things like that. And if you can get out, long lines and things like that, you're one step closer to being discharged.
I guess from my point of view, first thing is, have they got bacteremia? So is there a fixed duration that we need? For example, like it's not usually Staph aureus if it's in the abdomen, but there are some organisms that you might, for example, Enterococcus, you might want a bit longer for IV antibiotics. And the propensity for endocarditis. So, and does the patient have any prosthetic valves and things like that? So sometimes we consider those things. Sometimes we consider, is the collection under pressure? So we consider the risk of bacteremia and sepsis in the patient. So if the collection's draining and it's not under pressure, you have to argue, okay, what's the utility of antibiotics? What's my end game? So as an ID physician, I'm going, okay, is that collection adequately draining? Is it going to continue to drain? Therefore, it's not going to cause bacteremia. Therefore, I can rationalize either stopping antibiotics early or that kind of thing. And then also it's, are there any other risks to the patient? So for example, I saw a patient on the weekend who had intravenous antibiotics, but also had C. diff. So then you're like, okay, what are the other downsides to the patient? So, and that might push us to stop earlier. So, we might actually push for operations or source control or whatever if we can see that that person's going to get worse with the antibiotics. I don't think I answered the question, but...
You've definitely shared your thought process, both of you. Thank you so much. That's fantastic, and all very valuable factors to consider. So I guess the next step as part of the picture, given the patient's part of the treating team, how much do you feel a patient's preference for IV versus oral antibiotics would influence your decision around treatment?
You want to go first, Michael?
I think most patients would probably prefer not to have indwelling tubes in their body. Like we see patients, they don't enjoy having surgical drains, nasogastric tubes, and just by sheer extrapolation of that, having cannulas, PICC lines, central lines. And most patients that we see would prefer to minimise their hospitalisation stay. So if there's a way to do that safely, either by changing to an oral equivalent or converting to a hospital in the home program, then we would employ that. The caveat is, like, we don't use the HITH program all that much for intra-abdominal infections. It's just the really I didn't go into pancreatic necrosis in my talk, but they're the ones who probably we would sort of use the most. Generally, we get some sort of source control before they're ready to go home.
My feeling is that patients believe us. So if we say they're okay on orals, they generally are okay with that. And we actually just started some qualitative HITH data, actually, of talking to patients about experience, and also HITH doctors and things, which is not analysed or complete yet, but certainly patients generally say, look, I just do what the doctors tell me. So I think it's our doubts about the value of oral antibiotic that are the key. And are they good enough? And have we given long enough? And yeah, and I think bravery around those decisions is something we have to teach junior doctors and nurses and pharmacists.
Can I just go back to the presentation of the illness? It's sometimes it's what the GP says or the neighbour says or the relative, which is the most powerful thing. So with the intravenous antibiotics for the uncomplicated diverticulitis, you try and manage them as an outpatient. But my doctor said I need intravenous antibiotics. I need to come to hospital, and that's the challenge that often you're fighting against. And I think it's going to take a whole generation to properly overcome that, of young doctors coming through into practice, be it emergency physicians, GPs, etc., etc.
That's a really interesting comment, Michael. I was just wondering, actually, around that community hospital interaction that you've alluded to. I guess posing to the whole panel, just asking the question around multidisciplinary care for these patients, and opening up that discussion around GP-led care versus hospital-led care in some of these situations. Have you guys had any experience with that, or do you have any particular thoughts around that?
Jen?
Well, we have a GP-led HITH program. But they work within our hospital, but they're certainly GPs. So actually, although we are actually advocating for some ID involvement, but we certainly have co-management with them. So we also have an ID clinic where we see the ones that are on IV antibiotics, but it's certainly GP-led. So I guess, yeah, I mean, I guess, were you asking about GP HITH, or were you asking about GPs managing them without HITH processes?
Kind of bit of both, I guess. The pre-hospital as well as post-hospital, so post-discharge or transfer, just their role, I guess, in that setting, Jennifer.
I think everything's about communication, isn't it? And access to, education, communication, access to people for information if things are going wrong. So I think safety is, if you discharge someone, I'm sure a GP can manage it if they've got ability to discuss with us and get hold of us if things are going badly and, all that kind of thing. I think that's the key, is that how do you facilitate really good kind of primary care communication with the hospitals?
Yeah, I totally agree that communicate. If someone who's really complex, has frequent admissions, a lot of unpronounceable antibiotics, it must be completely overwhelming for a GP to know what to do when they come with like an unexpected turn of events. And so the default for them is just, refer back to the hospital. On the other hand, if you give, your GPs, other primary care, healthcare providers, some specific, requests or recommendations so they can follow along. And when the patient deviates from that pathway, it's easy for them to have a name and a face to contact to, you know, pick up the pieces.
Excellent, thank you so much. Now we're getting some questions coming through from the attendees as well, which is fantastic. So we've just got a comment from Sam Tapp, who said, from a nurse's point of view, I often hear those comments that Michael's just shared about patients expecting IV antibiotics. It takes a gold star to communicate that clearly, which is fantastic. And we've got a question around HITH antibiotic stability in the HITH process. So I guess, you know, Jennifer alluded earlier to a paper around meropenem usage for appendicitis. I guess just asking the question to the broader panel in terms of your experience with choosing antibiotics for intra-abdominal infections for HITH. How does the role and the stability of the drug play a role? And I guess as a pharmacist, that's something that I always think about. But in your experience, is it the go-to go for Triaxone once daily, or is it go for something a bit more innovative? And how would you consider those factors?
Actually, the paper I was referring to was using ertapenem. I think it was a once daily carbapenem. It was an overseas paper. But yeah, look, I'm not, I mean, Jason Roberts is probably better at antibiotic stability than I am. You know, there are obviously antibiotics we can't use easily in outpatients, and that poses problems. So, you know, it's not easy to use ceftazidime, and, you know, it's not easy to use. There's lots of different antibiotics that we find it difficult to use. So I don't know if Jason wants to comment from a pharmacy perspective. I sometimes feel caught between a rock and a hard place. You know, I either choose something broader spectrum, which is more stable and gets the patient out of hospital, or I don't. You know, it's tricky.
Yeah, I agree. And I think, Nicolette, you're probably even in a better position to answer it. So maybe we're all going to have a go at some stage. But it's just an awareness of what the stability data is and whether or not you can use your preferred antibiotic. And each time that the stability data doesn't match, then you just sort of need to compromise a little bit. Of course, backing up exactly what Michael and Jennifer have said throughout both of their presentations is that if oral can be used, then, you know, that's even better, and it's preferred for lots of reasons. So I think that that's what my answer to that would be. Of course, there's increasing levels of data describing how we can prepare some drugs traditionally not stable, such that we can increase their stability. So maybe it can be given as an IV continuous infusion, but yeah, it's all a bit of a give and take.
Absolutely, and I agree. I think the role of therapeutic drug monitoring is very interesting, but you do often wonder, Jason, I guess, about those concentrations at the site of infection. And I guess asking the broader panel in terms of the research, have you guys got any awareness or any go-to research that helps you make a decision around those antibiotic choices to make sure that we've got those optimal concentrations at the site of infection, given this class of patients or group of patients?
Can I just expand on that, just to get some, to put some more context around that question? It was more so when I thought about that, it was in the context of, say, diverticulitis, whereby a drug's given orally versus IV. Do you think, is there any data to suggest that that actually may result in better local concentrations because it is an orally administered drug? Or is it the case that, you know, if it is a severe diverticulitis, that you really do want to have IV therapy until the inflammatory process and has died down and the patient's on a much better clinical trajectory? Because obviously we rarely measure concentrations of drugs in this scenario. And yeah, for some of the drugs, of course, we can't measure concentrations either.
Absolutely. And James has just written a fantastic comment in the Q&A chat, and I'm just inviting him to share that with the group because I don't think I can quite do it justice. So James, do you want to share with the group around your question and comment around perioperative use of antibiotics?
James may not be a panelist, so he may not be able to talk.
That might be it. My apologies. Sorry, James. So I'll just quickly share it with you guys. Just you know, taking a step back, we've talked a lot around treatment during tonight's session, but yeah, just going back to basics and thinking about the perioperative use of antibiotics, the role and choice, also in terms of dosing and timing, and thinking about those high-risk patient groups, I guess is a really important consideration to reduce your risk of surgical site infections. I guess Jennifer and Michael, in your practice, you've obviously both dealt with this in your day-to-day work, but also in your research. Have you got any pointers, I guess, for our attendees in terms of what's your process when you think about perioperative antibiotics in your patients and identifying those high-risk procedures as well as patient groups?
So just a couple of questions that James has mentioned about repeat intraoperative dosing as well, I guess. It's really uncommon with intra-abdominal operations. Not many of them go beyond 4 hours. So in our study of 1,700 patients, I think there was only a couple that needed redosing. So I think timing's often poor, and often that's because there's an acute infection. And so people go, oh, well, they're on Tazocin or triples, and therefore they don't get perioperative antibiotics, but actually the levels aren't often right at the time that they're having an operation. So it's still useful to give perioperative prophylaxis. I guess you often can't change, like, you know, some operations like an elective knee, you know, they're elective, aren't they? You can choose to not have them in a high-risk patient, but an intra-abdominal infection, you can't always choose not to do it. So some patients are just going to be high risk, aren't they? And so I guess, you know, what you want to do is optimize your dose of your perioperative antibiotics and your choice and your timing, and you know, but I guess prolonged duration isn't necessarily the answer.
The advent of the surgical safety checklists in recent years has really been helpful in bringing, at least talking about antibiotics in the immediate preoperative or just before knife to skin. So it may have actually led to an overuse, perhaps, in some people with clean elective surgery who don't benefit from it. That's an unintended consequence, but I think it's probably the plus side is it's captured a lot more people. What it doesn't sort out is the appropriate dose. And again, we saw the guidelines for Kefsol, you know, go increase to 2 grams and 3 grams for the really obese patients. And it took, again, interaction with the AMS team to really bring that to our attention. And as we discuss it, you know, on every case, it just becomes sort of standard for us.
That's really helpful. Thank you so much. Just talking about, I guess, that social influencing that you presented on, Jennifer, our local surgical team have recently spearheaded bringing up some posters that they were using at their surgical scrub sinks. And they felt that 5 minutes that they needed to scrub was well spent deciding on the antibiotic prophylaxis for their patients. And that actually came from a registrar level. So it's fantastic when they come up with suggestions that they feel would make a difference in their practice, and then implementing that. So small step, but in the right direction.
Actually, one of the surgeons in our group said to me the other day that that one of the other sites in my study actually did put them above the scrub area, and that he thought that would be helpful for us to do at SCU as well as the operating theatre wall. And, you know, I said, whatever you want is absolutely fine. Ours have got so big now, though, because we actually list the operations that don't need it as well as the ones that do, because actually I think people often need permission not to use antibiotics as much as they need permission to use them. So actually they're so big that I'm not sure whether we're going to be able to fit them. But yeah, I think wherever is helpful and wherever people have ideas, support them and encourage them.
Absolutely, can't agree more. So last question that we've got, by any new ones coming through the chat, it's just around thinking in the era of antibiotic resistance. In your practice, Michael and Jennifer, is there anything that you've come across in terms of a personalised approach to thinking about empiric therapy in those patients with colonisation of multi-resistant organisms pre-surgery, or is there a process that you've got in place in your practice to make sure that screening is done to help guide therapy?
Again, over my career, I've seen a transition from, surgeons' default standard was triple IV antibiotics to, maybe piptazes, like the initial knee-jerk reaction now. In terms of treatment, in terms of prophylaxis for the more complex colonised patients, I believe that we have a very good relationship with our AMS team, and we can pick up the phone, or our anaesthetist can pick up the phone and say, okay, this is the deal. What do you recommend? And we get instant gratification, essentially all the time for that.
That's great. Fantastic. Thank you so much. So I'll hand over to Jason, but just before I do, I'd just like to thank Jennifer and Michael again for fascinating presentations, but also sharing their wealth of experience and their tips for new players, such as myself, in the surgical environment, and knowing that there is definitely a role for HITH, but we still have a way to go in the surgical arena. So thank you so much, and handing over to Jason.
Fantastic. Thanks, Nicolette. And a huge thanks to Raquel, of course, but Michael and Jennifer as well. It was a fascinating session, and I really enjoyed it, and I'm grateful to everyone that's also been able to join us online. As is usual, all of these presentations have been recorded and they'll be available on our YouTube channel. So please feel free to revisit these and take notes about all the excellent advice that was provided from our excellent speakers. I'd like to draw everyone's attention to our next CRE